How does this work? Do you just show the podcast? How do you do it?
I will. You mean after the interview, how to
Yeah.
publish it? Okay. After our interview, I will do the editor, and after edit, and we will publish on our WeChat website. And
Okay,
I will
sounds good.
set you link. Okay.
Good.
So okay, let's start. The first question, antithrombotic therapy after PCI has always been the focus on attention. As a reviewer of the paper, would you please share us the latest research progress in this field?
Yeah, antithrombotic therapies are the cornerstone of our treatment of patients after stenting, PCI, etc. And over the years, they've really evolved as we begin to think about the differences and how different patients have different outcomes with different durations, etc., of antithrombotic regimens. And while you might prescribe or recommend a certain length of treatment with dual antiplatelet therapies, not one size fits all. So over the years, one of the, we've always, when we stop dual antiplatelet therapies, we've reverted to aspirin. And I think that these last few years, we're now evolving into perhaps a novel approach of dropping aspirin and staying with the P2Y12 inhibitor monotherapy. And that's sort of a new evolving regimen that seems to be effective. It still has good outcomes in terms of ischemic complications, in minimizing ischemic complications, and as well as reducing bleeding. So there's no ischemic harm, and there's a huge bleeding benefit with going to a P2Y12 monotherapy. It is also important to note that the reason why I think we're able to do this and shorten the duration, de-escalate, or go to a single antiplatelet regimen with a P2Y12 monotherapy, all of it is because of the incredible stent technology improvement in PCI techniques, as well as use of physiology and imaging. All of these things have improved our ischemic outcomes, so now we can manage antiplatelet therapies better.
Okay, so the next question. Your team has also conducted research on antithrombosis after PCI. What are the results it has achieved so far? What is the next research direction?
Yeah, so we felt it was important to address the question of a P2Y12 monotherapy compared to dual antiplatelet therapy in high-risk patients, in patients in whom we would be giving a potent P2Y12 inhibitor like ticagrelor. And can we minimize that bleeding issue that we're seeing and keeping the patients on a longer duration of a potent P2Y12 inhibition by having a dropping of the aspirin. And so we designed the Twilight trial in a double-blind, placebo-controlled fashion. We randomized 7,119 patients. We had a wonderful result with with a massive increase in bleeding complications, with no issue about ischemic events. We were able to accomplish this with our colleagues from China. We had a wonderful engagement of Chinese sites, and we were able to work together, and we're most thankful for the wonderful collaboration we had with Professor Han Yaling, and we were able to perform this. Our next goal now is to see for how long can we keep the can we drop the aspirin sooner than 3 months, and we're designing larger randomized trials in that way, looking at different regimens.
Okay, thank you. And the last question, DAPT is the standard regimen of antithrombotic therapy for PCI patients, and its treatment duration has always been controversial. In your opinion, what are the main factors that determine the duration of DAPT?
Yeah, I mean, I think that's a really good question. The duration of dual antiplatelet therapy has not yet been optimized. There's no one size fits all, as I said before, and that it has to be individualized to the patient's risk. And so there is that understanding that if we uh, use the patient's demographics and understand what's their risk profile, understand the burden of atherosclerosis, and especially if they have peripheral arterial disease, extra cardiac manifestations of atherosclerosis, I think those patients are at high risk, and you really want to keep them for as long as possible on, especially on a P2Y12 inhibitor. And I think that with patients who are at high bleeding risk, you really want to de-escalate and shorten the duration of DAPT. And we have the ARC-HBR criteria that really helps you, evaluate who those patients are. And I think that's a very, very good way of using that kind of patient profile to be able to mitigate risks and improve outcomes of our patients.
Thank you so much. Thank you
You're
to
welcome.
talk with me. Okay.
You're
Okay,
welcome.
done.
Thank you.
Thank you.
Bye-bye.
Bye. Have a good day.